Good morning, colleagues. Today we will talk about the role of immunohistochemistry in the diagnosis of the hemoblastoses. So, what is a hemoblastoses? That is a group of malignant disorders of the lymphoid tissue and the bone marrow. First of all, we will talk about the lymphomas. Lymphoma is a group of blood cell tumor that develop from the lymphocytes in the peripheral, more often in the peripheral lymphoid tissue. Of course, it's malignant tumor. We never talk about the lymphoma like a benign. It's only malignant. There are two main types of lymphoma: Hodgkin lymphoma and non-Hodgkin's lymphoma. Risk factors for the Hodgkin lymphoma include infection by the Epstein-Barr virus and having other in the family with this disease. Risk factors for non-Hodgkin's lymphoma include a lot of different factors like autoimmune diseases, HIV, AIDS, infection with a human T lymphotropic virus, diet with a large amount of the meat and fat, immunosuppressant medication, and some pesticide. Epidemiology. About 74,000 new cases of the non-Hodgkin lymphoma are diagnosed in Europe each year. In children, they are the third most common cancer when we talk about hemoblastoses generally. Non-Hodgkin lymphoma makes up about 90% of all cases and include a large number of subtypes. Symptoms. Clinical picture. First of all, it's a local features like lymphadenopathy, swelling, enlargement of the lymph nodes. Systemic symptoms, which can be associated with both Hodgkin and non-Hodgkin lymphoma. They consist of fever, night sweats, weight loss, except that we can see loss of appetite and anorexia, fatigue, respiratory distress syndrome or dyspnea, itching of the skin. Why we separate the Hodgkin lymphoma from the non-Hodgkin's? Hodgkin lymphoma is a small group which includes just 6 main histological subtypes, and the non-Hodgkin's is very big group of the diseases. So why? Because we have fixed etiological factors which cause Hodgkin lymphoma. It's Epstein-Barr virus. We have typical bright morphological picture and distinctive clinical features. Grossly, what do we see? In the case of lymphoma, affected lymph nodes, more often it's lateral cervical lymph nodes, are enlarged, but their shape is preserved because of the capsule is not invaded. Usually, the cut surface is whitish gray and uniform. In some histological variants, like in nodular sclerosis, we can see nodular pattern and maybe thickness of the capsule. Cells, histology, main histological features of the Hodgkin's lymphoma, that is rich Nebeck cells. It's also known as lacunar histiocytes or certain types. There are different giant cells found with a light microscopy in biopsy from the individuals with a Hodgkin's lymphoma that are usually derived from the B lymphocytes. Rich Nebeck cells are large and are either multinucleated or have a bilobed nucleus. It's resembled to OI appearance with a prominent and significant inclusion like nucleoli. So we can see 2 eyes, or maybe 3 sometimes, with a bright nucleoli in the center, which look like oli. These cells will be positive for CD30 and CD15. Subtypes of the rich Nebeck cells. A special type of rich Nebeck cells is lacunar histiocyte, whose cytoplasm retracts when a fixation, so the nuclei give the appearance of the cell that lie with the empty spaces like lacuna. These are characteristic of the nodular sclerosis subtype of Hodgkin's lymphoma. Next, it's a mummified rich Nebeck cells, with a compact nucleus, basophilic cytoplasm, no nucleolus. It's associated with the classical Hodgkin's lymphoma. Popcorn cells, it's a small cell with a hyperlobulated nucleus, and small nuclei are associated with a nodular lymphocyte predominant Hodgkin's lymphoma, and we can see it here on this picture, low picture. Classic Hodgkin lymphoma. Classic Hodgkin lymphoma is a monoclonal lymphoid neoplasm derived from the B cells composed of mononuclear Hodgkin and multinucleated Hodgkin-rich dendritic cells residing in an infiltrate containing a variable mixture of the non-neoplastic small cells like lymphocytes, eosinophils, neutrophils, histiocytes, plasma cells, fibroblasts, and collagen fibers. There are 4 histological subtypes of the classical Hodgkin lymphoma: lymphocyte-rich type, nodular sclerosis, mixed cellularity, and lymphocyte-depleted variant. The 4 subtypes have identical immunophenotypic and genetic features, but different clinical features, and sometimes it's associated with Epstein-Barr virus. Cytolocation. First of all, main place of the location of this tumor, it's cervical lymph nodes. Sometimes mediastinal, axillary, and para-aortic lymph nodes. Rarely is non-axial lymph nodes like mesenteric, epitracheal, or Valder's ring. Primary extranodular involvement are also rare. More often we can see the localized disease, which only on the first or second stages. Splenical involvement, as you see, it's only 20% of cases, bone marrow in 5% of cases. Splenic and abdominal involvement more frequent in mixed cellularity subtype. Gross appearance. We can see enlarged, encapsulated lymph node with a fish flash appearance on the cut surface. Nodular sclerosing subtype characterized by the prominent nodularity, dense fibrotic bands, thickened capsule. In the case of the injury of the spleen, we will see scatter nodules on the red color base of the cross section, like in this picture. A lot of small whitish color nodules. Sometimes maybe a big single mass of the tumor. Thymus may have cystic degeneration and epithelial hyperplasia. Morphological subtypes. We will start from the nodular sclerosis. Nodular sclerosis, that is the most common subtype of the Hodgkin lymphoma in developed countries. It affects females slightly more than males and has median age of onset at 28 years old for young adults. It is the most common subtype and is composed of the large tumor nodules showing scatter lacunar classical rich dendritic cells that in the background of the reactive lymphocytes, eosinophils, and plasma cells with the varying degrees of the collagen fibrosis. Here you can see the pinkish color, it's collagen fibers, which localize around the atypical like follicle, like nodule, which compose of the tumor cells and the reactive lymphocytes. More often, nodular sclerosis takes place in the cervical lymph node and mediastinum, as you see it, 80% of cases. Also, it may be spleen, lung, bone marrow, liver. Clinically, it's mostly second stage of the disease. B symptoms we can see in 40% of cases. What does it mean, B symptoms? B symptoms is used to refer to fever, drenching night sweats, and loss of more than 10% of body weight over the 6 months. Treatment shortly. Better overall prognosis than other type of classical Hodgkin lymphoma. It's good prognosis for the patient. 90% of survival at 5 years for early stage of the disease. Adverse prognostic indicator, it's a massive mediastinal disease. Nodular sclerosis, characterized by the, of course, nodular pattern with a broad fibroblast, poor birefringent collagen bands surrounding at least one nodule. Here you can see the collagen fibers, pinkish color, the histiocytes, plasma cells, lymphocytes, and bright pink, it's eosinophils. Usually, it's confirmed with a thickened lymphonodular capsule, higher variable number of the Hodgkin-Richterberg cells, small lymphocyte and other inflammatory cells, often numerous eosinophils, histiocytes, neutrophils, occasional forming macrophages. Mitosis are uncommon. Hodgkin-Richterberg cells have more lobated nuclei, smaller lobes, less prominent nucleoli, more cytoplasm than other type of classic Hodgkin lymphoma. Lacuna cells. As we said before, it's a formalin fixation artifact which leads to the changing of the shape of nucleus and presence of the lacume, empty hole around this nuclei. It's associated with necrosis and histiocytosis, and we name it necrotizing granuloma-like formation. Immunohistochemistry. First of all, for identification of the nodular sclerosis, we use CD15 and CD13. These are the markers which give the positive staining for the Hodgkin-Richterberg cells. Additionally, we can use fascin, vimentin, and of course Epstein-Barr virus marker, which can be positive but only in 10–40% of cases. Next subtype is a mixed cellularity subtype. It's a common subtype and is composed of the numerous classic Richterberg cells admixed with numerous inflammatory cells, including lymphocytes, histiocytes, eosinophils, and the plasma cells, without sclerosis. This type is most often associated with Epstein-Barr virus infection and may be confused with the early so-called cellular phase of nodular sclerosing classical Hodgkin's lymphoma. Epidemiology. 20–25% of all cases of classic Hodgkin's lymphoma in the developed countries. More frequent in the human immune deficiency patient in developing countries. No bimodal age distribution, median age 38 years old, with a male predominance, 70% of the patients. Clinical features. Enlargement of the cervical and supraclavicular lymph nodes. Spleen in 30% of cases, bone marrow 10% of cases. Other location is rare. B symptoms. We said it before. Symptoms are frequent. 50% of patients have a first diagnosis when the disease on the stage 3 or 4 with abdominal lymphonodular splenic involvement. It's not good for prognosis, of course. Microscopical description. A phase lymph node architecture. Interfollicular pattern also possible. May have interstitial fibrosis, but no breadth bands of sclerosis or capsular thickening. Typical Hodgkin-Richterberg cells in a variable inflammatory background. Eosinophils, histiocytes, neutrophils, plasma cells. May have a prominent epithelioid histiocytes that may form granulomas, especially in cases which positive for the Epstein-Barr virus infection. Next subtype, it's a lymphocyte-rich or lymphocyte predominance. Lymphocyte-rich classical Hodgkin lymphoma is a subtype of classic Hodgkin lymphoma with scattered Hodgkin-Richterberg cells and a nodular or less commonly diffuse solid background consisting of the small lymphocytes and with the absence of the neutrophils and eosinophil. 30% of nodular lymphocyte predominant Hodgkin lymphoma cases diagnosed in the past was found to be lymphocyte-rich classic Hodgkin lymphoma, also known as a follicular Hodgkin's lymphoma. Epidemiology. It's 5% of all classic Hodgkin's lymphoma, median age higher than in other subtypes, so it's around 43 years old. Male predominance. Location. Peripheral lymph nodes, typically mediastinal, and bulky disease uncommon. Lungs maybe in 4% of cases, bone in 3% of cases, and other rare location. Clinical features. Most of the patients have stage 1 or 2. B symptoms in this case will be rare. Microscopic or histological description. What do we have? We have two growth patterns. Sometimes it's nodular, more commonly, and diffuse in the rare cases. Attenuated T-zones, nodulars, composed of the small lymphocytes, may have eccentric, small or regressed germinal center, no eosinophils or neutrophils. Some of the Hodgkin-rich Tabak cells may resemble LP cells or mononuclear lacunar cells, easily confused with the nodular lymphocyte predominant Hodgkin lymphoma. Rarely, a lymphocyte-rich classic Hodgkin's lymphoma, typical nodules surrounded by the fibrous bands, may be classified as a nodular sclerosing classic Hodgkin's lymphoma, is more appropriate. Coexisting lymphocyte-rich classic Hodgkin lymphoma and mixed cellularity classic Hodgkin lymphoma possible but rare. Lymphocyte depleted is a rare subtype composed of the large number of often pleomorphic rich Tabak cells with only a few reactive lymphocytes, which may easily be confused with the diffuse large cell lymphoma. Many cases previously classified within this category would now be reclassified under anaplastic large cell lymphoma. Epidemiology. It's less than 1% of all classic Hodgkin's lymphoma of Western countries. Rarest subtype. Most common in developing countries, often HIV-associated, median age 30-37 years old. Male predominance. Site. 90% of cases have subdiaphragmic disease or organomegaly. Predilection for retroperitoneal lymph nodes, abdominal organs, and bone marrows. Bone marrow involvement is common in more than 50% of cases. And in 50% of cases, we can see peripheral adenopathy. Clinical features. It's diagnosed more often in more advanced stages like stage 3 and stage 4, and with the B symptom at presentation. More aggressive than other subtypes, including in HIV-positive patient. Patient often present with the B symptom, as I said before, may be part of continuing with the mixed cellularity subtype. Microscopical description. Either diffuse fibrosis or reticular form. Diffuse fibrosis form. Complete assessment of the nodular architecture by abundant disorderly connective tissue with pus-positive fibrinoid material and hypercellular background. Rare rich Tabak cells. Classified as nodular sclerosis, classic Hodgkin lymphoma, if nodular and sclerotic. Reticular form. No disorderly connective tissue. Numerous bizarre rich Tabak cells, often in sheets with a few lymphocytes. Bone marrow. Rare rich Tabak cells is amorphous, known by a refrigerant eosinophilic background material and inflammatory infiltrate. We also can see on the multiple section level often required to diagnosis. It's better to a diagnosis to make a lot of section. Uninvolved bone marrow is normocellular with increased eosinophils. May resemble mixed cellularity classic Hodgkin lymphoma. Sarcomatose pattern with a pleomorphic Hodgkin-Rich-Steinberg cells, difficult to differentiate from anaplastic large cell lymphoma. May have coagulated necrosis or sinusoidal invasion. Here you can see clinical example of the lymphocyte depleted variants with the location of the tumor in the spleen. We can see on the picture B histology with multiple bizarre Rich-Steinberg cells, some erythrocytes and reactive lymphocytes. Here immunohistochemistry CD15, which stain in brown color, and CD30, which also give the positive staining. And on this picture you can see immune fluorescentic method, which give the positive reaction in the cells which affected with Epstein-Barr virus. Next, nodular lymphocyte predominant variant. B-cell neoplasm characterized by the scattered clonal cells termed LP cells in a background of reactive lymphocytes and histiocytes with a mostly nodular and sometimes diffuse growth pattern. LP cells, originally termed lymphocytic and histiocytic cells, have enlarged nuclei with the lobial contours and variably prominent nuclei. Essential features. LP cells initially arise with altered follicles. Background small B cells are numerous and in early phases and decrease with the time. LP cells rosettes by CD4 positive, PD1 positive T cells. Number of background T cells increase over time along with the loss of the nodular pattern. Diffuse pattern resemble T cells, histiocytes reach large B cells lymphoma. LP cells display germinal cells centers B cell phenotype CD20 PAX5. BCL6 also positive but negative CD10. CD30 is variably positive and if positive usually weak. Most cases negative for CD15 in contrast to all other previous variants of the Hodgkin's lymphoma. Histology. Usually total replacement of the nodular architecture by expansive vague nodules of small lymphocytes with sparse, relatively large tumor cells with a multilobulated round nucleus, thin nuclear membrane, finely granular chromatin, and variably small nucleoli. We name it popcorn cells. May have rim of normal lymphoid nodule. Large cells are called LP cells. LP cells are a mixture with numerous small B lymphocytes, epithelioid histiocytes, and CD21 positive follicular dendritic cells. Scant eosinophils, plasma cells, or fibrosis also will be seen. Prominent sclerosis is unusual but may occur in all division. Small germinal centers are rare between the nodules and usually present only at the compressed edge of normal lymph node tissue. No or rare classic Rich-Steinberg cells, also LP cells, may be occasionally resemble to Rich-Steinberg cells in some variants. No well-formed granulomas, although epithelioid histiocyte may be prominent. Diffuse pattern has a background of reactive T cells. Staging. Hodgkin's disease is staged depending on how far the cancer has spread. Staging is the primary method for determining both treatment option and prognosis. Stage number 1. Disease is limited to a single node region or has involvement of the one neighboring area or a single nearby organ. Stage 2. Disease is limited to 2 or more lymph nodes at the same site of diaphragm above or below, but only in one side, or extend locally from the lymph node into the nearby organ. Stage 3. Disease is in the lymph node of the both sides of the diaphragm, or has spread to the nearby organ, spleen, or both. Stage 4. Disease has become widespread, involving organs outside the lymphoid system at all, so generalized spreading. Complication and causes of the death in the lymphoma, in the Hodgkin lymphoma. It's intoxication, first of all, septic complication and other secondary infection, and also uremia, which caused by the renal amyloidosis, which lead to the chronic fibrosis, to insufficiency of the kidney, and of course uremia. Now we will talk about the non-Hodgkin's lymphoma. It's a diverse group of the blood malignant tumor that include any kind of lymphoma except Hodgkin's lymphoma. Type of non-Hodgkin lymphoma vary significantly in their severity, from slow growing to very aggressive. Causes: it's infections, chemicals, radiation and chemotherapy, genetic disorder, and autoimmune diseases. Infections: first of all, it's of course viral infection. It's Epstein-Barr virus, human T-cell leukemia, hepatitis C virus, human immune deficiency virus. But also some bacteria like Helicobacter pylori. It's associated with the formation of the mouth lymphoma of the stomach. Chemicals: it's maybe different, like dioxin, herbicides, and other medical treatments. As I said before, it's radiation or chemotherapy. Genetic diseases which may associated with non-Hodgkin's lymphoma. It's Klinefelter syndrome, Hediak-Higashi syndrome, ataxia telangiectasia syndrome. Autoimmune diseases: Sjogren syndrome, celiac-sprue rheumatoid arthritis, and systemic lupus erythematosus. Classification of the non-Hodgkin lymphoma includes several positions. First of all, it's cell morphology. It's classified into the small cell lymphoma and large cell lymphoma. Small cell lymphoma is when the tumor cells around the size of mature lymphocytes. Large cell lymphoma is when it's in 5-6 times more than small lymphocytes. Higher proportion of the large cells is associated with aggressive of the disease, aggressive duration of the disease, aggressive course. Second, it's a growth pattern. It can be diffuse or follicular. In a follicular pattern, cells form aggregates resemble lymphoid follicles, but without germinal cells. It's not real follicles, it's a tumor follicles. According to lymphocytic maturation, we also classified it into the lymphocytic, lymphoblastic, centrocytic, centroblastic, and immunoblastic, etc. High-grade non-Hodgkin lymphoma. Non-Hodgkin lymphoma is called high-grade when the cells appears to be dividing quite quickly. Some types of high-grade non-Hodgkin lymphoma will grow faster than others. More commonly, it's character for the elderly people over 50 years old. The high-grade non-Hodgkin lymphoma include some tumors of the B-cell origin, some is T-cell origin. In B-cell non-Hodgkin lymphoma, we can see diffuse large B-cell lymphoma, the most common type of high-grade lymphoma, Burkitt lymphoma, mantle cell lymphoma, primary mediastinal B-cell lymphoma, primary central nervous system lymphoma. In T-cell variants, we can see peripheral T-cell lymphoma, anaplastic large cell lymphoma, angioimmunoblastic T-cell lymphoma, enteropathy-associated T lymphoma, adult T-cell lymphoma, leukemia, and nasal type NK or T-cell lymphoma. Low-grade non-Hodgkin lymphoma is called low-grade when the cells appears to be dividing slowly. This means that low-grade non-Hodgkin lymphoma can take a long time to develop. They are also called indolent non-Hodgkin lymphoma. The low-grade non-Hodgkin lymphomas include follicular lymphoma, the most common type of the low-grade, chronic lymphocytic leukemia or small lymphocytic lymphoma, lymphoplasmacytic lymphoma, gastric malt lymphoma, non-gastric malt lymphoma, splenic marginal zone lymphoma, nodular marginal zone lymphoma. Here you can see the big picture with a lot of different markers which can help us to classify non-Hodgkin's lymphoma according to the cell region. Different cells have different receptors which can help us to find which cells is tumor cell in this case, which cells gives the rise for the tumor mass. Prognosis. The overall 5-year relative survival rate for people with a non-Hodgkin lymphoma is 69%, and the 10 years relative survival rate is 58%. We can use the International Prognostic Index, which divided prognosis into the good factors and the poor prognostic factors. Good prognostic factors include age 60 or below, stage 1 or 2 of the tumor, no lymphoma outside of the lymph nodes or only in the one area, performance status able to function normally, so the patient feel good, and serum lactate dehydrogenase level is normal. In other cases, the prognosis will be poor. Complication and causes of the death. First of all, it's secondary infection. We also can see infertility. Second, primary cancers, superior vena cava obstruction, when the lymphatic nodule of the cervix, which is enlarged, block the veins, compress it. Compression of the spinal cord, gastrointestinal obstruction, bleeding and perforation of the intestine. Leukemia. It's a malignant neoplasm of the various white cell type in circulating blood, and they are precursors in the bone marrow. Epidemiology. In 2020, we can see the 60,000 of the new cases of leukemia. And in deaths, in this case, it takes place in 3.4%. Generally, deaths with a diagnosis of leukemia in this year is 23,000, and it's 3.5% of all cancer deaths. 5-year relative survival 63.7. It is the most common type of cancer in children, with 3/4 of leukemia cases in children being acute lymphoblastic leukemia. It occurs more commonly in the developed world. The exact cause of the leukemia is unknown. Both inherited and environmental factors are believed to be involved. Risk factors include smoking, ionizing radiation, some chemicals, prior chemotherapy, and Down syndrome. Clinically and pathomorphologically, leukemia is subdivided into the variety of large groups. The first division will be acute and chronic leukemia. Acute leukemia is characterized by the rapid increase in the number of immature blood cells. Immature, first of all. Immediate treatment is required in acute leukemia due to the rapid progression and accumulation of the malignant cells, which is spill over into the bloodstream and spread to another organ of the body. Acute forms of leukemia are the most common form of leukemia in children. Chronic leukemia is characterized by the excessive buildup of relatively mature but still abnormal white blood cells. Typically, taking months or years to progress, the cells are produced at a much higher rate than normal, resulting in many abnormal white blood cells. Chronic leukemia mostly occurs in older people, but cancer rarely occurs in any age group. Additionally, the diseases are subdivided according to which kind of blood cells is affected. This split divides leukemia into the lymphoblastic or lymphocytic leukemia or myeloid or myelogenous leukemia. In lymphoblastic or lymphocytic leukemia, the cancerous changes take place in the type of marrow cell that normally goes on to form of lymphocytes. Most lymphocytic leukemia involves B cells. In myeloid or myelogenous leukemias, the cancerous changes take place in the type of bone marrow cells that normally goes on to the form of red blood cells and the platelet. Classification based on the number of leukemic cells in the 1 microliter of the peripheral blood. It can be leukemic variant of leukemia. It's when we see the more than 25,000 of leukemic cells per 1 microliter. Subleukemic, when the figure is from 50,000 to 25,000. Leukopenic, it's a reduced leukocyte count in peripheral blood. And aleukemic, it's when the leukemic cells are absent in the peripheral blood, but present in the bone marrow. Acute leukemia has some characteristics. For example, that is a hiatus leukemicus. Hiatus leukemicus appearance in the blood when we can see the blast cells in the peripheral blood together with the mature cells, but without the intermediate stages of the cells. Acute leukemias are characterized by the replacement of the bone marrow by the blast cells and infiltration of the spleen, liver, kidney, lymph nodes, brain, and other organs by these cells in a varying degree, with the formation of the localized aggregate of these cells, which we name leukemides. Acute lymphoblastic leukemia or acute lymphoid leukemia. In a person with acute lymphoblastic leukemia, lymphoblasts are overproduced in the bone marrow and continuously multiply, causing damage and death by inhibiting the production of the normal cells in the bone marrow and by spreading infiltration to another organ. Acute lymphoblastic leukemia is the most common in childhood, with a peak incidence at 2-5 years of age and another peak in old age. Signs and symptoms. First of all, it's a generalized weakness and a fatigue, anemia, dizziness, frequent and unexplained fever and infections, weight loss and loss of appetite, excessive and unexplained bruising, bone pain, joint pain. It's caused by the spreading of the blood cells in the surface of the bone or into the joint from the bone marrow. Breathlessness, enlarged lymph nodes, liver, spleen, kidney, pitting edema, as it's showed on the lower picture. When we press the skin, we can see pitting on this area because of swelling. Petechiae, which are teeny red spots or lines on the skin due to the lower platelets level, because excessive growth of the tumor cell lead to the inhibition of the other cells in the bone marrow. It's red blood cells and, of course, thrombocytes. Leukemic infiltration is most expressed in the bone marrow, spleen, lymph nodes, mucus-associated lymphoid tissue in the gastrointestinal tract, and a kidney. Bone marrow in this case has a crimson red color. Spleen is greatly increased red color with an indistinctive pattern. Mesenteric and mediastinal lymph nodes enlarge, gray and pink. Lymphoblasts contain glycogen around the nucleus. Accumulation of the lymphoblast in the substance and membranes of the brain and spinal cord called neuroleukemia. Phenotype. For identification of the acute lymphoblastic leukemia, more often we use flow cytometry, but also we can use immunohistochemistry. Acute lymphoblastic leukemia in the B cells are typically positive to TDT marker, CD34, CD19, and cytoplasmin 22, and other markers. Surface immunoglobulin is usually absent in these cells. Myeloperoxidase should not be expressed. Myeloid-associated agents CD13, CD33, and CD117 may be co-expressed without it being B phenotypic. Stage of B lymphoblast differentiation has antigenic correlates. Early precursor B cells acute lymphoblastic leukemia, like pro-B acute lymphoblastic leukemia, has a positive reaction to CD19, cytoplasmic 79A, cytoplasmic CD22, and nuclear TDT. Common acute lymphoblastic leukemia positive to CD10. Late pre-B cells acute lymphoblastic leukemia gives a positive reaction to CD20 and cytoplasmic heavy chains. T acute lymphoblastic leukemia typically for TDT, CD34, CD99, and CD1A. Only cytoplasmic CD3 expression is considered lineage specific. So we can differentiate B from T only because of the positive CD3 reaction. T acute lymphoblastic leukemia is often double positive for CD4 and CD8. Other T cell associated antigen variably expressed, including CD2, CD5, and CD7. Acute myeloid leukemia is also known as acute myelogenous leukemia or acute non-lymphocytic leukemia. Acute myeloid leukemia is the most common acute leukemia affecting adults, and its incidence increases with age. The symptoms of acute myeloid leukemia are caused by replacement of the normal bone marrow with the leukemic cells, which cause the reduction in the red blood cells, platelets, and normal white blood cells. Several risk factors and chromosomal abnormalities have been identified, but the specific cause is not clear. Acute myeloid leukemia have some symptoms and signs. Of course, it's anemia, lack of platelets which lead to the bruising and bleeding, bone and joint pain, persistent and frequent infection, like in other type of leukemia. Enlargement of the spleen more character for acute myeloid leukemia, but is typically mild and asymptomatic. Like lymphatic node swelling is rare in the acute myeloid leukemia. The skin is involved about 10% of the time in the form of leukemia cutis. Rarely sweat glands, paraneoplastic inflammation of the skin. Some patients with acute myeloid leukemia may experience swelling of the gums because of the infiltration by the leukemic cells, with sometimes necrotizing gingivitis. B cells chronic lymphocytic leukemia, also known as chronic lymphoid leukemia, leukemic disorder of CD5 positive, CD23 positive tumor cells, usually B cells, that are small, round, low-grade with saccable appearance. Monoclonal disorder characterized by the progressive accumulation of the functionally incompetent lymphocyte. It is the most common form of leukemia found in adults in Western countries. Symptoms include enlargement of the lymph node, liver, spleen, recurring infection, loss of appetite or early satiety, abnormal bruising, fatigue, night sweats, chronic myelogenous or myelocystic leukemia, also known as chronic granulocytic leukemia. It is a form of leukemia characterized by the increased and unregulated growth of predominantly myeloid cells in the bone marrow and the accumulation of these cells in the blood. Chronic myeloid leukemia is a clonal bone marrow stem cell disorder in which a proliferation of mature granulocytes like neutrophils or eosinophils and basophils and their precursors is found. It is a type of myeloproliferative disease associated with a characteristic chromosomal translocation called the Philadelphia chromosome. This type of leukemia has two stages, monoclonal benign and malignant polyclonal. The first stage lasts for several years, is characterized by the progressive leukocytosis and enlargement of the spleen. The second, terminal stage, lasts 3-6 months and is characterized by the appearance of the blast forms. We name it blast crisis, accompanied by an increase in the spleen, liver, lymph nodes, leukemic infiltration of the skin, meninges, nerve trunks, hemorrhagic syndrome develops. Morphologically, bone marrow, gray-red or gray-yellow. We also name it pyoid because of the presence of the lot of neutrophils. Except neutrophils, we can see here promyelocyte blast and atypical, so with a malformed nuclei. The spleen is greatly increased. Its mass reached 6-8 kgs, dark red color where there is ischemic infarctions. Microscopically, follicles are atrophied, sclerosis takes place, hemosiderosis, diffuse leukemic infiltration. Liver significantly increased, 5-6 kgs. Its surface is smooth. Leukemic infiltration along the sinusoids, hemosiderosis, fatty degeneration of the hepatocyte take place. Lymph nodes are enlarged significantly, gray-red and soft. Next variant of the hemoblastoses, that is a multiple myeloma, also known as a plasma cells myeloma, myelomatosis or Collar's disease. Bone marrow-based multifocal plasma cell neoplasm associated with a monoclonal immunoglobulin. We name it M protein, and we can find it in the serum and urine. Diagnosis requires synthesis of clinical, laboratory, radiological, and histological findings. Serum or urine M protein, clonal plasma cells in a bone marrow, and presence of an organ damage critical for diagnosis, especially if less than 10% of plasma cells or M protein level below threshold. Clinical variants: asymptomatic, non-secretory, and plasma cell. Asymptomatic or smoldering, more likely to progress to symptomatic myeloma than monoclonal gammopathy or uncertain significance. Both show gammopathy without symptoms. Risk of progression 10% per year for the first 5 years, low risk if no progression in the first 5 years after diagnosis. Non-secretory myeloma, less than 5% of cases. Its 15% non-producer serum-free light chain may still be detected. Lower incidence of renal insufficiency, hypercalcemia, and depression of normal immunoglobulin G. Plasma cell leukemia, aggressive with a short survival. May be primary plasma cell leukemia or represent as a late-stage transformation. Typical lack of CD56 positive cells, more frequent abundant karyotype. Bone pain and osteolytic lesion less common. Myeloma cells have ability to survive and grow outside the marrow, typically associated with the extramedullary region, like in the skin, pleural effusion, lymphadenopathy, and organomegaly. Main clinical features of the multiple myeloma include CRAP, its elevation of the calcium level, C, R, renal failure, A, anemia, and B, bony lesion. Bony lesion leads to bone pain, of course, especially in the spine and chest. Also, we can see in the patient nausea, constipation, loss of appetite, mental fogginess or confusions, fatigue, frequent infection, weight loss, opportunistic infection like pneumonia, and anemia also. In these cases, anemia have a normocytic and normochromic character. The spectrum of renal lesion that is seen in a patient with myeloma include myeloma kidney, or cast nephropathy, when we can see in the renal tubule cast consisting of the proteins which form from the immunoglobulins. Light chains amyloidosis, material. Monoclonal immunoglobulin deposition disease, less frequently cryoglobulinemic glomerulonephritis, and proliferative glomerulonephritis. Myeloma bone disease is due to the overexpression of receptor activator for nuclear factor B ligand, RUNCL, by bone marrow stroma. RUNCL activate osteoclasts which resorb the bones. In the results, we can see the bony lesions which look like a punctured out defect. It's resorptive lesion, including the P-parapod appearance on the skull and radiography. The breakdown of bone also leads to release of calcium into the blood, leading to hypercalcemia and its associated symptoms with metastatic calcification. Microscopical features. In a core biopsy, we can see interstitial cluster, node, and sheet of plasma cells. Areas of the bone marrow may be spared with the preserved hematopoiesis. Other cases may have a diffuse involvement in markedly suppressed hematopoiesis. Prominent osteoclastic activity may be seen. Immunohistochemistry to quantify plasma cells, stained for kappa and lambda to establish clonality. On the right side, you can see the picture with CD138 positive plasma cells diffusely. And on the left picture, A and B, you can see that we have a clonality, kappa, not lambda. Thank you for your attention.